Division of Rheumatology was born in 1971. Its coming into being is closely linked to the life of one great woman, Dr. Lourdes Manahan. In 1953, Dr. Lourdes Manahan joined the Department of Medicine. She headed the PGH dispensary where she accumulated patients with gouty and rheumatoid arthritis. After a few years, she went to the United States to study with prominent rheumatologists in several teaching hospitals. Upon her return to the Philippines in 1962, she laid the groundwork for the subspecialty and established the section of rheumatology in the Department of Medicine, now known as the Division of Rheumatology. During those early years, Dr. Manahan was the section of rheumatology. As the only rheumatologist in the country, she multitasked as clinician, teacher, researcher, and mentor. She was professor in the College of Medicine and the doctor in our charity outpatient department arthritis clinic as well. She represented the country in various international fora, putting the Philippines and the University of the Philippines in the international rheumatology community. In 1968, Dr. Clemente Amante came home from his rheumatology training in the US and joined Dr. Manahan in the section. He helped Dr. Manahan in the Herculean effort to establish the fledgling subspecialty and attract trainees to the field. In 1981, a formal fellowship program in rheumatology at PGH was established, the first of its kind in the Philippines, with Dr. Rosario Nadora as the first fellow in training. From there, the section of rheumatology grew, and by the late 1980s, the section had graduated 5 rheumatologists, all of whom stayed in the country to render service. Interest in the field boomed in the 90s, and after 40 years, its graduates can be found in 15 of the 18 regions of the country, serving patients with rheumatic diseases. The division is continually involved in the undergraduate teaching of the College of Medicine by participating in learning units for 2nd to 5th year. It also actively participates in the residency training of the Department of Medicine. The residents' subspecialty rotation exposes them to more rheumatic diseases common in the country and to the details of diagnosis and management that are often not seen in the general services. The division reaches out to update doctors about developments in rheumatology through the Lourdes Manahan Lectures in Rheumatology. On its 18th year, this postgraduate course is held annually in the PGH but has also traveled to many provinces in Luzon and Mindanao before the pandemic. We also engage with our patients outside the clinics through the Lupus Club of PGH and Abacada ng Rheuma lectures at the PGH OPD and social media through Facebook and the division website page. The division staff continues to pursue the zeal for research and discovery in medicine and rheumatology that Dr. Manahan inculcated. Its publications have found a niche in local and international books and journals. Amidst the present pandemic, the division continues its tasks to educate, to discover, and to serve. We embrace the mission of service to the underserved and to those with rheumatic diseases. As we celebrate the Golden Jubilee of the Division of Rheumatology, we strive to continue the legacy of its founding faculty in training competent specialists to care for our patients, produce relevant researches, and serve the country.
Good afternoon. We are coming to you live from the University of the Philippines, Manila, for the 18th Lourdes Manahan Lectures in Rheumatology. I am Dr. Paulo Lorenzo, a consultant from the Division of Rheumatology, and I will moderate this afternoon session. I would like to thank our sponsors, Johnson & Johnson, Novartis, and Healthcare Celtrion for participating in this webinar. To all our participants, thank you for joining us today. To welcome us, let me introduce the Chief of the Division of Rheumatology, Professor Evelyn Salido.
Good noon to everyone. The Division of Rheumatology would not be here without our founder, Professor Lourdes Manahan, and our mentors who continued her work, Professors Clemente Amante and Esther Pensurga. To the former and current Fellows of Rheumatology who are now or will soon be leaders in their own institutions, let us continue the pioneering work of our mentors to improve the care for patients with rheumatic diseases in our country. Let us dispel the notion that rheumatic diseases are the natural effects of aging and bad habits, and increase the public's awareness that these are diseases that can be treated and, if not properly attended to, can cause unnecessary disability or even death. To our patients, we promise to study and work more to help you as long as you're willing to help yourselves too. To our administrators, our department chair, Dr. John Añonuevo, Director Gerardo Legaspi, Dean Charlotte Chong, and Chancellor Carmencita Padilla, and the past department chairs, directors, deans, and chancellors over the past 50 years. Thank you for believing and supporting us. To you, our participants in our LMLR webinars, I thank you for your interest to know more about rheumatic diseases and in your partnership in helping our patients get better. I hope you enjoyed the lecture. Thank you.
Thank you, Professor Salido. If you have any questions, you can place them at the Q&A box, and we will address them during the open forum after the lecture. You will receive your certificate of participation to this webinar a week after you submit the evaluation form and post-test. The link will be posted at the Q&A box and at the chat box midway through the webinar. LMLR is an annual event hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. This last lecture of the year's LMLR will focus on psoriatic arthritis and its treatment. Our distinguished speaker for today completed her medical residency and rheumatology fellowship at the Philippine General Hospital. Currently, she is a clinical associate professor and is the present training coordinator for the Department of Rheumatology in PGH. She is also the rheumatology representative for the Ortho-Geriatric Fracture Liaison Service of the hospital. Her service extends to other institutions, as she is also an active consultant at Medical Center Manila, San Juan de Dios Hospital, and Hospital ng Maynila Medical Center. Dr. Santiago's passion for research is evident on her work as research specialist in the field of SLE genetics. She has also participated as clinical investigator in numerous clinical trials that have helped expand clinical evidence of rheumatologic conditions. Let us welcome Dr. Angeline-Therese Santiago to discuss selecting the best fit for psoriatic arthritis treatment. Dr. Santiago.
Hello, good afternoon. Kamusta po kayong lahat? I hope everyone who is tuning in today is doing well, is safe and healthy, and I hope we learn something new today. Before I start my lecture, I would just like to thank our division for giving me the honor and privilege to be a part of this year's Lourdes Manahan Lectures in Rheumatology series. The topic today is psoriatic arthritis, treatment goals and guidelines. I'm sure my rheumatology mentors and colleagues will agree with me when I say that psoriatic arthritis is probably one of the most exciting conditions in the field of rheumatology today. Firstly, because psoriatic arthritis patients have such distinct and varied manifestations that really it's never a boring time when you're managing these patients. The second reason is that we have newer effective drugs for psoriatic arthritis based on our deeper understanding of its pathogenesis. You know, it was not too long ago when we had very few treatment options and we mostly borrowed from our management of rheumatoid arthritis. But that is no longer the case today. Our objectives for today include a review of psoriatic arthritis clinical presentations and diagnosis, our goals of treatment, and the application of recent guidelines for optimal management. Brief review of psoriatic arthritis. So PSA is a chronic multi-system inflammatory musculoskeletal disorder which affects a quarter of patients with psoriasis. And unlike other autoimmune conditions like lupus and rheumatoid arthritis, it does not seem to have a female predilection. It can cause a variety of patterns, which we will review later. I'd like to think of PSA as the hippie bohemian member of the group of inflammatory arthritis because, like a true bohemian, it likes to break the rules in terms of clinical manifestations and joint involvement. PSA affects 6 main domains, which includes the joints, the enthesis, dactylitis, the spine, the skin, and the nails. It is also associated with diseases such as uveitis, more commonly anterior uveitis, and inflammatory bowel disease. It has associated comorbidities like cardiovascular disease, metabolic syndrome, and psychological impairment. It is important to remember these domains and associated conditions when evaluating patients with psoriatic arthritis, as they directly impact on treatment decisions and prognosis. So let's focus now on the joints and review the 5 clinical subtypes of psoriatic arthritis. These subtypes may coexist and they may change over time. So the first subtype is your distal interphalangeal predominant involvement, which typically occurs with other PSA subtypes and is quite common, affecting 50% of Asian patients. If it is present, it is useful as it may help differentiate from rheumatoid arthritis, which typically spares the DIPs. Our second subtype is our asymmetric oligo or monoarthritis, which is the most common subtype of psoriatic arthritis and accounts for about 70% of cases. The third subtype is your symmetric polyarthritis, meaning it affects more than 4 joints, and it presents similarly to rheumatoid arthritis. The fourth subtype is your spondyloarthritis, which affects the spine in your sacroiliac joints. But unlike ankylosing spondylitis, the axial involvement in psoriatic arthritis is more asymmetric. And finally, you have arthritis mutilans, a very destructive form of arthritis, wherein the patient develops shortened digits, also known as telescoping and flail digits. Other musculoskeletal manifestations of PSA include enthesitis, meaning inflammation where a tendon, ligament, or joint capsule inserts into the bone. The most common manifestations are Achilles tendonitis and plantar fasciitis. Dactylitis is also known as sausage digit, is the inflammation of the whole finger as opposed to just the joints. And if you put an ultrasound probe up against the inflamed finger, you would see flexor tenosynovitis and subcutaneous soft tissue swelling. It is considered a hallmark of psoriatic arthritis and will affect up to 50% of patients. More importantly, its presence portends a more severe disease, meaning more joint involvement and radiographic progression. As to the extra-articular domains, the first is skin disease, and majority of patients with psoriatic arthritis will also have psoriasis for 10 years prior to the onset of their arthritis symptoms. But important to note that 15% will not, meaning 15% will either have joint and skin involvement develop at the same time, or the arthritis might precede skin disease. Lastly, we have nail disease, which occurs in the majority of patients with psoriatic arthritis, and this includes onycholysis and pitting. It is important when you're taking your history and doing a physical examination to do a thorough examination of the nails and skin and look at the hidden areas where psoriasis lesions might be hiding, such as the scalp, the back of the elbow, the back of the knees, the intergluteal cleft, and in the umbilicus. Early diagnosis is important so we can treat early and prevent damage and disability. We do not really have a diagnostic criteria or even diagnostic labs to definitively diagnose PSA. We do have the CASPAR criteria, which is a classification criteria used in clinical trials, meaning this is a research tool which takes into account evidence of psoriasis, including family history, psoriatic nail dystrophy, the absence of rheumatoid factor, dactylitis, and imaging findings. A score of 3 and above can classify the patient as having psoriatic arthritis. Again, this is just a classification criteria used as a research tool, but it may be used as a guide in clinical practice to help in the diagnosis of psoriatic arthritis patients. So psoriatic arthritis is truly a heterogeneous disease involving 6 main domains and is associated with different diseases and comorbidities. Its diagnosis should be based on the overall clinical and imaging features and evaluation of these different domains and associated conditions. So like in any other disease condition, or in anything really, goal setting is important. And for psoriatic arthritis, the primary goal is to maximize health-related quality of life. So that's such a lofty goal, which we can achieve through abrogation of inflammation, through control of symptoms in all domains, meaning to achieve remission and, as an alternative, low disease activity, to prevent structural damage, to normalize function, maximize social participation, and of course, avoid or minimize complications. So this slide summarizes the 2017 Treat to Target recommendations. And this paper sort of gives us a blueprint on how to achieve our goals for our patients. So number one, or the first in the recommendations, would be the recommendation to treat to target. This concept has been used successfully in many chronic diseases such as diabetes, rheumatoid arthritis, and lupus. But what it means is to achieve or target the goal of remission, meaning the lack of disease activity or the absence of disease activity. An alternative target would be low disease activity. And in order to measure if you are achieving your target, it is recommended that you use validated measures. So we will go into details of this later. So goal setting should be a shared decision between the patient and the physician, and it should be individualized and coordinated, meaning the management should be inclusive of the management of your musculoskeletal condition and your extraarticular manifestations. So these are the different instruments or validated measures that determine disease activity. The green boxes represent the clinical and laboratory manifestations included in the instrument. So in the 2017 updated treat to target recommendations, disease activity for psoriatic arthritis and minimal disease activity should be considered as the validated measures to define your target. So the MDA includes in its evaluation different clinical domains: articular, your enthesitis, skin, pain and function, without the inclusion of laboratory parameters. Now the psoriatic arthritis disease activity in psoriatic arthritis validated measure includes only the articular manifestations with pain assessments and inflammatory markers. So a combination of these two measures to be used in the clinics can be easy in determining disease activity and if you are meeting your targets. So I'd like to share that I have this nifty little app in my phone called Ruma Helper. And in this app, it contains different disease activity measures, including DAPSA. So this is something that I use when I evaluate my patient with psoriatic arthritis. And this is something that you can also show to your patient to let them know where you are in their management. So the key takeaways here are, number one, to have a target in mind. And ideally, the target should be clinical remission or, if not feasible, low disease activity. So this is something that needs to be discussed with your patient. And in order to determine if you are achieving your target, you need to use objective assessment through validated measures. So this could be through DAPSA or MDA or other validated measures depending on the domain involvement in your patient. But most importantly, goal setting in psoriatic arthritis should be a shared decision between you, the physician, and the patient. And the management of your patient should be holistic, meaning you do not just focus on one domain, but you must consider the involvement of other domains as well as associated conditions. So now let us discuss the treatment guidelines and their application to clinical practice. As doctors, we love guidelines. Guidelines allow us to be updated in the most current evidence, minus the backbreaking work of individually going through all the studies by ourselves. The guideline makers gather stakeholders, they sift through, digest, and evaluate up-to-date scientific evidence for us, and finally come up with recommendations based on the evidence, and sometimes if the evidence is lacking, by broad consensus, which we can then use in clinical practice. In psoriatic arthritis, we have three major guidelines for management, and these come from the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. The latest version is set to come out this year, anytime this year. And then we have the 2019 updated EULAR recommendations. This is from the European Alliance of Associations for Rheumatology. And finally, we have the 2018 American College of Rheumatology National Psoriasis Foundation Guidelines, which is more of a national guideline for American patients. Okay, So like I said earlier, it's amazing how much has changed since 2015 to 2016, the years when GRAPPA, EULAR, and ACR published their recommendations prior to the more recent updates. We now have significant additions to our treatment toolbox, such as the newer biologic DMARDs, IL-17A inhibitors, your secukinumab, ixekizumab, your IL-23 and IL-12/23 inhibitors like your guselkumab and ustekinumab. We also have your targeted synthetic DMARDs such as your JAK-STAT inhibitors like tofacitinib and PDE4 inhibitor apremilast. These biologic DMARDs on top of our usual symptomatic therapies and CSD MARDs. So let us discuss a case, and we will try to manage this case based on what the guidelines tell us. So this is a 42-year-old male complaining of hand pain for 18 months. And on examination, you noted synovitis of the distal interphalangeal joints, the wrists, the knees, the ankles. And he said that this swelling has been going on for the past 6 months. It is also associated with prolonged morning stiffness. And this patient has a history of plaque psoriasis since he was 17 years old, treated with light therapy and topical steroids. This patient is obese, and on laboratory examination, he was negative for rheumatoid factor. So you diagnose this patient with psoriatic arthritis based on the clinical manifestations and history of psoriasis. So how will we treat this patient? We can definitely give NSAIDs for symptomatic relief, local steroid injection as adjunctive therapy. But the bigger question is, should we start this patient on disease-modifying anti-rheumatic drug? And if we were to start a DMARD, should it be a conventional synthetic DMARD, or should we proceed straight to biologic DMARD? So the first important update in the EULAR 2019 guidelines is the stronger distinction according to phenotype. We now distinguish between polyarthritis and oligoarthritis, because we know that the number of synovitis is one of the strong drivers of radiographic progression. So the recommendation is to start conventional synthetic DMARD, namely methotrexate, at an earlier time upon diagnosis. So our patient presented with polyarthritis, so definitely he is a candidate for conventional synthetic DMARDs based on the EULAR recommendations. If we are in the US and we use the ACR NPF 2018 guideline, then we would probably treat our patient differently. As you can see here, the ACR NPF 2018 is quite bold because it actually recommends TNF inhibitor as first line in active treatment-naive patients over oral small molecules such as methotrexate, sulfasalazine, and apremilast. Note the use of the term oral small molecules, as the guideline makers in ACR 2018 disagree on applying the term DMARD or disease-modifying anti-rheumatic drug to methotrexate and the likes due to their perceived lack of evidence to its disease-modifying effect or the prevention of radiographic progression. This recommendation was based on data showing superiority of TNF inhibitors over methotrexate. Indeed, trials comparing the efficacy of methotrexate to biologic DMARDs show that your TNF inhibitors are superior to methotrexate monotherapy. For example, in the SEAM-PSA trial, which evaluated the efficacy of etanercept monotherapy, etanercept in combination with methotrexate and methotrexate monotherapy. And as you can see in this graph, the patients given given etanercept, as shown by the green bar graphs, performed better in the ACR 20, 50, 70, and MDA activity measures compared to the patients given methotrexate monotherapy. And also significant to note that the addition of methotrexate to etanercept did not significantly increase the efficacy of the drug. Another trial is the GODACT trial, which is a randomized controlled trial that compared golimumab plus methotrexate to methotrexate alone. And you can see that the golimumab plus methotrexate arm, represented by the green bars, performed significantly better across all disease activity measures. This is part of the GRAPPA 2021 guidelines. Again, the final paper is set to be published anytime soon, but the results have been presented in different major rheumatology conventions this year. In the GRAPPA 2021, you can see that conventional synthetic DMARDs is considered a first-line treatment option for peripheral arthritis, while biologic DMARDs is considered an alternative first-line option. And this is because of its strong evidence of efficacy based on randomized controlled trials. But significant to note that they still included conventional synthetic DMARDs in the algorithm or in the management as first-line management of peripheral arthritis. And that is because there are other factors to be considered apart from efficacy data. Admittedly, we have very limited data from small randomized controlled trials evaluating methotrexate in psoriatic arthritis. So the level of evidence remains weak if we were to base it on RCTs. But it doesn't necessarily mean that it doesn't work in the real world setting. We have good observational data, namely from TICOPA and other observational trial registry data, showing methotrexate can control disease activity. In the TICOPA, a quarter of patients on methotrexate monotherapy achieved MDA at week 24, as represented here by the pink bars. And modest responses can also be obtained using the other disease activity measures of arthritis, such as the ACR 20, the ACR 50, and the ACR 70. Bottom line, although the evidence for methotrexate from randomized controlled trials is not that strong, and in head-to-head trials with biologics, biologic DMARDs truly emerge superior to methotrexate. Despite this, methotrexate still very much remains a first-line treatment option, especially in our setting where cost and biologic DMARD availability are issues. So going back to our case, he was started on methotrexate initially at 10 milligrams per week and slowly up-titrated to 20 milligrams per week. However, after 6 months of treatment, there was persistence of active arthritis, and there was now note of skin lesions despite methotrexate and topical therapy. These manifestations have caused impaired function and disability. So what's the next step? In EULAR 2019 recommendation, in patients with peripheral arthritis and an inadequate response to at least one conventional synthetic DMARD, therapy with a biologic DMARD should be commenced. So the second step of treatment would be a biologic DMARD, and any one of the 3 categories of biologic DMARDs is recommended to be used. This is quite new, since I remember as a fellow, the usual practice would be to start TNFI over other options. But now the 3 biologic DMARDs are on equal footing in the domain of peripheral arthritis. So this new and updated recommendation is based on head-to-head trials. So it's so amazing that we have head-to-head trials comparing biologics. In the Spirit H2H trial, wherein ixekizumab, an IL-17A inhibitor, was compared to adalimumab, a TNF inhibitor. And looking at their efficacy on the arthritis domain with the endpoint of ACR 50 at 24 weeks, the results were comparable, and ixekizumab was non-inferior to adalimumab. In the EXCEED head-to-head study, another IL-17 inhibitor, this time secukinumab, was compared to adalimumab, a TNF inhibitor. And again, the results showed similar efficacy or non-inferiority of secukinumab to adalimumab in achieving arthritis response or ACR 50 response. How about IL-23 inhibitors in psoriatic arthritis? The DISCOVER-1 and DISCOVER-2 trials showed that guselkumab resulted in ACR 20 responses of around 60%, which is similar to the efficacy of IL-17 inhibitors. And it also showed good efficacy in skin with a PASI 100 response of 45% in the DISCOVER-2 trial. We don't really have a head-to-head trial yet with guselkumab and other biologic DMARDs, but we do have this network meta-analysis which compared guselkumab every 8 weeks versus other treatment modalities in psoriatic arthritis. This network meta-analysis made comparisons using the ACR 20 response, the PASI 90 response or the skin response, and safety data. The results were quite interesting and showed that in terms of peripheral arthritis, as measured by your ACR 20 response, guselkumab matched up very well with other drugs. Although it seemed that intravenously administered TNF inhibitors did slightly better, but it was clear that guselkumab was better than, for example, apremilast and definitely placebo. In terms of the skin response, as measured by PASI 90, guselkumab was superior to a number of the different drugs, such as your TNF inhibitors. And in terms of safety, the class of IL-23 inhibitor medications show a very good safety profile with minimal incidence of serious infection and malignancy. So we said that in peripheral arthritis, the 3 classes of biologic DMARDs are on equal footing. But in the skin disease domain, the evidence points to superiority of your IL-17 inhibitor and IL-23 inhibitor over TNF inhibitors. So the EULAR 2019 recommendation states that when there is relevant skin involvement, an IL-17 inhibitor or IL-12/23 inhibitor may be preferred. Going back to the SPIRIT head-to-head trial, if you look at the endpoint of simultaneous achievement of arthritis response, as well as the skin response or the PASI 100 response, what the head-to-head trial showed was that at the 24-week primary endpoint, 36% of patients in the ixekizumab arm achieved this versus 28% with adalimumab, showing superiority. So this is a composite measure of the arthritis domain and the skin domain. And here you have superiority of ixekizumab. And when you look at only the skin domain or PASI 100 alone, again, ixekizumab was clearly superior to adalimumab. A similar result in the EXCEED H2H trial can be seen if you try to look at the composite endpoints of ACR 50 and PASI 100, and PASI 100 alone, which showed superiority of secukinumab over adalimumab. So in our patient with persistent arthritis who has failed conventional synthetic DMARDs And with significant skin involvement, upon discussion with our patient, he decided to go with an IL-17 inhibitor therapy of secukinumab. So another significant update in our guidelines is the inclusion of JAK inhibitors as an option for patients with peripheral arthritis and an inadequate response to at least one conventional synthetic DMARD and at least one biologic DMARD, or when a biologic DMARD is not appropriate, a JAK inhibitor may be considered. In patients with mild disease, an inadequate response to at least one conventional synthetic DMARD in whom neither a biologic DMARD nor a JAK inhibitor is appropriate, a PDE4 inhibitor such as apremilast may be considered. So these are new additions or new updates to the EULAR 2019 guidelines. In the GRAPPA 2021 guidelines, JAK inhibitors are listed as first-line biologic DMARD option for the domains of peripheral arthritis, psoriasis, nail disease, colitis, and uveitis, and as a step-up DMARD after NSAIDs for axial disease, enthesitis, and dactylitis. We do have evidence of efficacy of our JAK inhibitor tofacitinib in joint involvement in psoriatic arthritis based on the OPAL Broaden and OPAL Beyond studies. However, the effect on the skin appears to be less compared to other therapies like IL-17 and IL-23 inhibitors. There are newer JAK inhibitors such as upadacitinib and filgotinib, and there are ongoing trials such as the SELECT PSA with adalimumab as comparator, and it showed improvements in musculoskeletal domains and significant responses on skin disease. Okay, now let's proceed to a second case. This is a 25-year-old male complaining of low back pain and alternating buttock pain for the past 12 months, described as severe, disabling, and associated with morning stiffness of 3 to 4 hours. And this patient has a history of psoriasis since 20 years old, but currently had no active lesions on the skin on examination. The patient, however, presents with nail onycholysis and also complains of occasional arthralgia. So here we have a case of psoriatic arthritis with predominantly axial involvement. So in the 2019 EULAR recommendation, first line would still be NSAIDs and local glucocorticoid injections for psoriatic arthritis patients with axial involvement. And if disease activity is uncontrolled after 4 to 12 weeks of NSAID therapy, then a biologic DMARD should be considered. And when there is relevant skin involvement, IL-17 inhibitor may be preferred. So here, failure to achieve targets in the axial domain would require you to shift to a TNF inhibitor. And this is the usual practice, would be to start a TNF inhibitor in a patient who has failed NSAIDs after 4 to 12 weeks. The efficacy of TNF inhibitors is well established in spondyloarthritis or axial disease involvement. However, we also have data or evidence showing that IL-17 inhibitors can also be effective in the management of psoriatic arthritis, axial disease, such as as seen in the Maximize study, which evaluated the efficacy of secukinumab at 150 milligrams subcutaneous injection versus 300 milligram dose to placebo. And as you can see, secukinumab was superior to placebo at both doses in terms of achieving the ASAS-20 response. So there is clinical improvement, significant clinical improvement in your secukinumab group compared to your placebo group. So in the GRAPPA 2021 guidelines, for the axial disease domain, the medications are NSAIDs, TNF inhibitors, IL-17 inhibitors, or JAK inhibitors, on top of physiotherapy and NSAIDs in the background. I included here the domain of nail disease because our patient exhibited onycholysis or nail domain involvement. And the first-line treatment options would be topical therapies, conventional synthetic DMARDs, acitretin, JAK inhibitors, or you can go straight to your biologic DMARDs or your PDE4 inhibitors like apremilast. So this patient was started on NSAIDs and physiotherapy, and he was compliant to treatment, but there was still significant disease activity after 3 months of management. And this patient was wary of injections, hence the next treatment step was to use a JAK inhibitor for our patient. So this slide is an illustration that will be included in the GRAPPA 2021 recommendations. And the GRAPPA guidelines is quite unique because it makes its recommendations based on treatment domains. And here you can see the treatment options for the different domains of arthritis, axial disease, enthesitis, dactylitis, skin disease, and nail disease. So we are still waiting for the final paper of the GRAPPA 2021 guidelines. So one of the common questions that gets asked in the clinics by our patients is, can we discontinue or can we taper our medications? And it's good that the EULAR 2019 included an update on DMARD tapering, although the level of evidence is still quite low. But they recommended that in patients with sustained remissions, cautious tapering of DMARDs may be considered. So when you say sustained remission, this means that the patient has been in remission for the past 6 consecutive months. And the aim of tapering is to find the smallest effective dose and not really to stop treatment, because there is still sparse data suggesting a certain risk of relapse, either for joints or skin when tapering. Still, the task force decided to offer guidance on tapering since it is an important aspect of modern management, especially when sustained remission has been achieved, so that we can minimize treatment-related risks and to meet the patient's desires and demands, and of course, to reduce the cost of treatment. Although the level of evidence for non-pharmacologic management is low, this is an integral part of the management of your patients with psoriatic arthritis. Definitely, we should encourage them to stop smoking, and we should recognize the importance of exercise and recommend exercise over no exercise. In terms of the type of exercise, low-impact exercises such as Tai Chi, yoga, and swimming appear to be better than high-impact exercises like running. The patient may also undergo physical therapy, occupational therapy, weight loss if overweight or obese, and even there are also some small data on massage and acupuncture in psoriatic arthritis. So an important consideration is safety. You do not just base your decision on efficacy, but also safety should be an important factor. And there should be a balance. There should always be a balance between efficacy and safety. Definitely, we need to screen for TB, hepatitis, as the use of biologic DMARDs and our targeted synthetic DMARD can be associated with active TB and serious infections as adverse events or as complications. We should discuss the potential increased risk of infection with biologics. For example, in JAK inhibitors, we need to also discuss the issues of severe hepatic impairment, pregnancy and lactation, venous thromboembolism, and even zoster. I think zoster is quite common among patients who use JAK inhibitors. For our IL-17 inhibitors, one issue is fungal infection. So this is something that you need to bring up to your patients. And of course, you can't use it for your patient with colitis. Your TNFI inhibitors should not be used for patients who have heart failure of at least class 3 or 4. It would also be a good time to discuss vaccination in your patients who are about to be started on biologic DMARDs, as this will help in the prevention of infectious complications. Aside from efficacy and safety, there are other treatment considerations when making decisions, such as the presence of comorbidities like diabetes, CVD, metabolic syndrome, patient preference, things like comfort with injections, whether people would rather have less frequent administration or whether people need an oral option. And so these smaller decision-making factors can often help those small items. And then I guess something that we need to discuss always with our patient is cost, because the price of biological DMARDs is a serious limiting factor, especially in our setting. So we have a number of medications where we would expect a similar outcome. We would typically choose a cheaper option rather than one of the newer, more expensive drugs. So in summary, when we are managing our patients with psoriatic arthritis, it is important to recognize disease heterogeneity and to determine disease domains and comorbidities, which should be the main driver of our treatment decisions. Methotrexate is still a first-line option. We can still consider it as the anchor drug, especially in our setting. We now have newer biologic DMARD options, such as your IL-17 inhibitors, IL-23 inhibitors, together with your TNF inhibitors. We also have your targeted synthetic DMARDs, such as your JAK inhibitors. And when we are treating our patients, we need to treat to target to maximize health-related quality of life. It is also possible to taper DMARDs to the lowest possible dose in patients with sustained remission, and there should always be a balance between efficacy, safety, patient preference, comorbidities, and cost. Ultimately, treatment should be a shared decision-making between the physician and the patient. I thank you for your attention, and I'm now ready to take your questions.
Thank you very much for that excellent and exhaustive lecture and discussion on psoriatic arthritis and the updates of treatment, Dr. Santiago. So we have, if you have some questions, you can type it in the Q&A box. But we have some which we can already start with. And these actually pertain to the clinical manifestations of psoriatic arthritis. So for patients, this is from Dr. Salido. For patients presenting with symmetrical polyarthritis, how do we differentiate between rheumatoid arthritis and psoriatic arthritis?
Excellent question, Ma'am Evelyn. Thank you for that question. And I think that's something of a dilemma when we encounter patients like that, because we know that some of the drugs that work in psoriatic arthritis, like your IL-17 inhibitors, your IL-23, do not really work in rheumatoid arthritis and vice versa, because now we know that they have a difference in terms of pathogenesis. So I think one of the more important techniques to remember when you are evaluating a patient with psoriatic arthritis, and if you want to differentiate, you have to look at the other domains. And this, your skin evaluation, your nail evaluation will come in here, your exhaustive history taking, this will come into play. And of course, even if what I've encountered, or I don't know if other rheumatologists will agree with me, but I think the presence of DIP involvement can really be a clue, because usually if you have a psoriatic arthritis patient with DIP involvement, then that is something that will clue you in that this is probably more of a psoriatic arthritis case instead of a rheumatoid arthritis case. But yeah, so you go clinical, you look at the other domains, you look at the other features. Your rheumatoid arthritis will not present with dactylitis, will not present with enthesitis, and your psoriatic arthritis patient is usually negative when you test for rheumatoid factor or anti-CCP. So that's another major clue.
So thank you, Dr. Santiago. Here's a question from the audience. A very informative lecture. In your practice, what laboratory tests do you usually get prior to starting conventional synthetic DMARDs or biologic DMARDs?
Okay, a very practical question and a very important question. So we know that when you will start methotrexate, we know that one of the adverse events would be hepatic disease or liver disease. So this is something that you need to work up. You need to do a liver panel. You need to do a renal panel also to determine kidney function, since you will be maintaining this patient on long-term therapy. What else? We know that psoriatic arthritis is associated with numerous comorbidities, so I would screen for diabetes, I would screen for metabolic syndrome, I would probably order a cholesterol level in all patients, FBS, HbA1c in all patients, because we know that if you have these comorbidities, you are at risk for certain complications, right? Like cardiovascular disease and liver disease. So that will affect in your up-titration of medications. For biologics, definitely, aside from the liver and kidney function, you need to screen for occult or latent infection. I definitely do screen for latent TB and even hepatitis B and C. And depending on the profile of the patient, you need to also screen for HIV. So these are the factors that these are the laboratory tests, the parameters that you need to consider prior to starting a DMARD.
Thank you. Thank you very much, Dr. Santiago. Another anonymous question. How long do you give NSAIDs among patients with psoriatic arthritis, with oligoarthritis, and axial disease?
Okay, we have, in terms of axial disease, the guidance is more, let's say, clear-cut, right? Because in the EULAR 2019 guidelines, you start your first-line treatment for axial disease is actually NSAIDs, and the observation period is 4 to 12 weeks. And if you don't meet your target, so you use your validated measures to determine disease activity in your axial spine or your sacroiliitis, if it's not met, then you proceed with your biologic DMARDs. In terms of patients, for patients presenting with peripheral arthritis and other musculoskeletal conditions like oligoarthritis, enthesitis, dactylitis, your NSAIDs is given more as a symptomatic treatment. So it can be given as an as-needed basis. You don't really just maintain your patient in your using NSAIDs, especially if they don't show adequate response. You need to consider starting a conventional synthetic DMARD.
Thank you for that. We have a lot more questions coming in, so I hope you're okay. So
Nakapag-lunch na, sir.
is there a role of systemic steroids in the management of Yeah. Okay. Yeah. Is there a role of systemic steroids in the management of psoriatic arthritis?
Okay. The role of systemic steroids. When we say systemic steroids, that means you take it orally or intravenously. Unfortunately, our systemic steroids, we've always seen or we've always considered the danger of your skin disease flaring, especially when you taper this condition. So steroids are given more as an intra-articular or as an intralesional drug, as sort of an adjunctive therapy. For example, in patients with enthesitis, dactylitis, or even in your patients with monoarthritis. But it's not it's not such a clear-cut no, I think. No, it's not such a clear-cut no, especially if you already have your methotrexate in place or you already have your biologic DMARDs in place. And I've had several experience co-managed with dermatologists wherein they would actually allow the use of oral steroids, for example, in patients who cannot take NSAIDs, but only for a short period of time. And what is important is that your conventional synthetic DMARD is already there so that you decrease the risk of the skin possibly flaring once you taper the steroid, the oral steroid. Wala si Sir. Hi, Sir. Sir Paulo. So I see some more questions.
Thank you. This is a long question. Can you hear me?
Yes, sir. I can hear you po.
Yes. How do we go about the initial management of those psoriatic arthritis patients who fail to follow up with their rheumatologist and now come to an internist with Cushingoid features already? Of course, the patient will be returned to the rheumatologist. Thank you.
Wow. A hard, ano. Well, I think we've encountered cases like this, no? Wherein this is probably, most likely, this is someone who has been taking oral steroids for a prolonged period of time. So we know that, of course, you need to taper. So as a rheumatologist, that's something that you need to explain to the patient. The oral steroid that you're taking is something that is not really recommended as long-term therapy in a patient with psoriatic arthritis. But of course, because of the Cushingoid features, you know that there is already the presence of adrenal insufficiency. So you have to taper slowly and then go to the pathway that we've discussed earlier. We need to, I would think that this is a case of severe psoriatic arthritis because he has been taking steroids for a long time. So we would probably evaluate all the disease domains and then get the DMARD in. That's the most important thing. Okay, and then slowly taper your steroid and then work up for complications of prolonged steroid use like diabetes, osteoporosis. And so those are the things that you need to do when you encounter cases like this.
Okay, thank you. Here's another question. Thank you very much, Ma'am Ange, for the very clear lecture and making diagnosis and management of psoriatic arthritis easy to understand. How do you decide which domain to prioritize for treatment if all domains of the disease are present?
Okay, thank you. You're welcome also. And so this is something that you need to discuss and figure out with your patient because you need to ask your patient which domain is the one that is causing the most impairment, physical impairment, disability, And this is where your objective assessments, your validated measures will come in. Diba? You have your, and of course, if all domains are involved, you need to have a multidisciplinary approach. Diba? You need to have a team to manage this patient. The dermatologist, get the dermatologist in to help co-manage the skin domain. You need a physiatrist, your rehabilitation medicine, to help with the function. When you say all domains, so that means kasali rin ang colitis, may IBD ba siya, may uveitis, so very severe case. So I would definitely go clinical, use your objective measures or your validated measures, and then discuss with the patient. The good thing is the efficacy of your DMARDs overlap, diba? We have certain biologic DMARDs that will work in all disease domains, almost all disease domains, so that will help narrow down your choice. So, yun.
Okay. Thank you very much. Well, I think we've run out of time. It's 1 o'clock, and I'd like to thank everyone for the questions. Thank you, Dr. Santiago, for answering all the questions, and I'm sure our audience learned a lot from you today. So this afternoon, we learned how to make a very clear diagnosis of psoriatic arthritis. We realize it is a heterogeneous disease, and the management, you consider several domains from nails, skin, dactylitis, peripheral and axial arthritis, and enthesitis. We've learned that there are associated conditions, more metabolic syndrome, obesity, uveitis, inflammatory bowel disease, which should also be looked into. And with the management, we have to set our goals and exactly what we want to achieve and what our target is, and do an objective assessment. And we also learned that we have a lot of new treatment modalities available, primarily as biologics and with the JAK inhibitors. And of course, we should not forget methotrexate. So I'd like to thank Dr. Santiago again for this excellent discussion. I'd like to thank the Information Management Service Network team of UP Manila and sponsors Johnson & Johnson, Novartis, and Healthcare Celltrion. And thank you all for joining us. We hope to see you all again next year. Thank you. Thank you, Ange. Thank you. Have a good afternoon.